In this lecture, we're going to be discussing antihistamines. Histamine actually has very minimal clinical utility, though really the common pathological states that we use histamine for are allergic disorders and peptic ulcer disease. Histamine is a locally acting compound with prominent and varied effects through different systems. Within the vascular system, histamine will dilate our small blood vessels. It will increase capillary permeability. Within our respiratory system, within the bronchi, we know that histamine produces smooth muscle constriction. In the stomach, it can stimulate secretion of acid. And within the central nervous system, it can act as a neurotransmitter. In terms of tissue distribution, histamine is present in practically all tissue, with levels being especially high in our skin, lungs, and our GI tract. The histamine content of plasma is rather low. And within the periphery, histamine is synthesized and stored in two types of cells. Histamine can be found in mast cells and basophils. And mast cells are found on the skin and other soft tissues, where basophils are present within our blood. With both, histamine is stored in secretory granules. Within the CNS, histamine is produced by neurons with cell bodies in the posterior hypothalamus and with axonal projections to the frontal and temporal cortices of the other brain regions. It gets released from mast cells and basophils, produced by allergic and non allergic mechanisms. And here we're going to see and talk about the allergic role or the allergic release. Initially, we need an allergic release produced by the antibodies of the IgE or the immunoglobulin E class. These antibodies are going to be generated after an exposure to a specific allergen. For instance, for a patient that has a sensitivity or an IgE sensitivity, pollen and other certain allergens like that can cause an immune reaction. And once this is made, the antibodies become attached to the outer surface of the mast cells within the tissue or the basophils within the blood. When this individual is then now re-exposed to the allergen, it's going to be bound by the antibodies. By a mechanism that is not fully understood, this binding of an allergen to an adjacent antibody will create some type of bridge between these two antibodies. This process mobilizes intracellular calcium, and in turn, the calcium causes a histamine containing storage granule. It fuses with the cell membrane and it disgorges itself into the extracellular space. This allergic release of histamine requires prior exposure to the allergen, and an allergic reaction can't occur during the initial allergen exposure. So, if you are having a reaction, this is not the first time that you've been exposed to that specific allergen. So, then what is the role of histamine in an allergic response? Why do we need histamine in the first place? The reactions mediated by histamine and the other compounds like prostaglandins, leukotrienes, the intensity of the allergic reaction is going to be determined by the type of mediators that are involved. So here you're seeing with mild allergies like rhinitis, itching, or localized edema, this is going to be caused largely by histamine acting on the H1 receptor. So we're going to see very mild allergic reactions like acute urticaria or hives, or we might even have part of this allergic condition of mild transfusion reactions, all working on the same pathway. And these are generally responsive to antihistamine therapy. For severe anaphylactic reactions or anaphylactic shock, the reaction to the body is going to be bronchoconstriction, hypotension, and edema of the glottis. Histamine plays a minor role in this process in terms of anaphylactic shock. In this situation, it's the leukotrienes that are the principal mediators. So, using an antihistamine with severe anaphylactic reaction is not going to help very much. Instead, because we are working against the principal mediators of leukotrienes, epinephrine is a drug of choice. We can further break down histamine into two subtypes. We have the H1 antagonists, or H1 blockers, and we also have the H2 antagonists, or H2 blockers. So, if we are looking for an H1 blocker, we are primarily trying to produce a selective blockade of that H1 receptor. And the same is true with the H2 antagonist. We're producing a selective blockade of H2 receptors. So let's first look into the reasons why we would use an H1 versus an H2. For mild allergic disorders, we're picking the H1 antagonist. And for treatments that serve a purpose for gastric or duodenal ulcers, we're using the H2 receptor antagonist. H2 receptors are not used for the treatment of allergies. So then the next question is, what are the effects of histamine 1 stimulation and why are we trying to block it in the first place? Remembering that H1 causes vasodilation, when H1 receptors are activated, these small blood vessels will dilate. The small vessels meaning the arterioles and the venules. Vasodilation is prominent in the skin, on the face, and the upper body. So these areas will become warm and flushed because we have the vasodilation and blood is rushing to those areas. With extensive vasodilation, we might even see peripheral symptoms. And total peripheral resistance will decline and blood pressure then falls. So, vasodilation can also cause peripheral blood pressure to fall. Histamine 1 stimulation also increases capillary permeability. Once these H1 receptors are activated, they're going to increase the permeability, which will then lead to capillary endothelial cell contraction. With this contraction, it creates openings between the cells, and this is where you're going to get the leaky capillaries. These openings between the cells are going to produce fluid, protein, and platelets that are escaping. With the fluid and protein into the interstitial spaces, this is shifting the fluid, causing edema. And if the loss of intravascular fluid is substantial enough, blood pressure may also fall due to the increase in capillary permeability. With bronchoconstriction activation with H1 stimulation, we see that if histamine is administered to an individual with asthma, severe bronchoconstriction is going to follow, right? Because we're increasing the constriction of the bronchi. However, although our body makes histamine, so um, our body does make histamine, but if we allow exogenous histamine or histamine outside the body, it can increase the bronchial constriction on top of the bronchoconstriction that's occurring endogenously. Histamine is not the cause of bronchoconstriction that occurs during a spontaneous asthma attack, however. Consequently, antihistamines are not good for the use for treating asthma because they're non selective. Central nervous system effects, in terms of the H1 receptors, this is going to have a role in cognition, memory, and our sleep wake cycles. So, H1 receptors have a role in seizure suppression, modulation of neurotransmitter release, and also the regulation of energy and endocrine homeostasis as well. And there are some other effects of H1 receptors, primarily on sensory nerves that produce itching and pain. And this is why H1 activation can cause a patient to feel not only pain, but pruritus in those areas. So if we use an antihistamine, we are suppressing those type of symptoms. H1 activation also produces secretion of mucus. Now we're going to talk about H2 and the stimulation of H2. What happens? Well, the major response to the activation of H2 has to do with gastric acid secretion. It acts directly on the parietal cells of the stomach, promoting acid release. And although acetylcholine and gastrin are also helping in this regulation of acid, histamine has a more dominant role in the release of acid. And we know this because in the presence of an H2 blockade, the the gastrin, and the acetylcholine are unable to elicit acid secretion. So primarily it is within the H2 blockade of histamine. Within the first generation H1 antagonists, we have five different subgroups or five major categories, and really they're based on antihistamine efficacy, ability to cause sedation, muscarinic blockade, and others. And you can see that given the differences, you could judiciously select a drug to produce your desired effect without maximizing the undesired effect. So basically, you can pick something that is doing what you want it to do. And in most cases, it's having an anti allergic or antihistamine effect, but you can minimize undesired effects like sedation, for instance, which is a significant problem. And among first gen agents, we also have CNS suppression that we see with drugs like diphenhydramine and promethazine. For patients that are using alkylamines, they can produce an effective H1 blockade. However, they can cause a modest reduction in alertness. Now, if sedation remains excessive, even by changing to one of these drugs in this class, then you can also revert to using a second generation agent. Also, you can try that. And the levels of sedation are found on table 56.1. They're all designated, and you can see which is the most sedative and which is the least sedative. And I do want you to know that for the examination. Now, most first gen agents have significant anticholinergic properties. So, as a result, what do you get? With anticholinergic effects, you're going to have dry mouth, urinary urgency, and other typical anticholinergic side effects. We're drying the mucous membranes. So, then let's look at the basic pharmacology. Because of the historical use, the term antihistamine is still synonymously used to the subgroup of histamine antagonists that produce the H1 blockade. We don't typically use the term antihistamine when we're talking about the H2 receptor antagonists. So here we're going to continue to use the term antihistamine, though, interchangeably with H1 blocker and H1 antagonist, so all meaning the same thing. Yet, H1 antagonists that are available have similar antihistaminic actions. These drugs differ significantly in the side effect profile. Because of the differences, the selection of the prototype to represent the group isn't really feasible. So we have to go through and structure our discussion around one prototypic drug. We can't really do that, so we're going to discuss H1 antagonists collectively. And then you can see the differences among the individual antihistamines. These will also be addressed as appropriate to the discussion. So, globally, we're going to talk about them, and if there's anything to point out, I will do that. H1 antagonists fall into two major classification groups. So, we said we have the first generation H1 antagonists and the second generation H1 antagonists. The principal difference is that first gen antihistamines are highly sedative or provide a sedative effect. They're highly sedating. And second generation antihistamines don't tend to do that with most patients. How does this happen? To answer that question, we need to look at the mechanism of action. H1 blockers will bind selectively to H1 histaminic receptors. And with these receptors, they're going to block the actions of histamine at these histaminic receptor sites. H1 antagonists don't block H2 receptors, they're very selective. Additionally, they don't block the release of histamine from mast cells or from basophils. We should also note that although the interaction of classic antihistamines with histaminic receptors is limited to just the H1 receptor subtype, the drugs can also bind to non histaminic receptors. Most notably, there are certain antihistamines that can bind to and block to muscarinic receptors. This action underlies several of the side effects. So, not that they can bind to H2 receptors, but they can also bind to muscarinic receptors. So, what then are the pharmacological effects to the different areas of the body? Peripherally, the major therapeutic effect of an H1 antagonist can be attributed to the prevention of histamine at the receptor site. So, in the arterioles and venules of the skin, the blockers are going to inhibit the dilating actions of histamine. So, we're going to have a reduction in flushing happens localized flushing, and then also within the capillary beds, the antihistamines are going to prevent that histamine induced increase in permeability and leaking and the transfer of fluid and proteins causing edema. By blocking histamine at the sensory nerves, the H1 antagonists are going to reduce itching and pain. So, there are some benefits of the blockade of H1 receptors in the mucous membranes as well. It's going to help suppress secretion of mucus. But what about the central nervous system? Within the central nervous system, antihistamines can cause both excitation and depression of the CNS. With therapeutic doses, antihistamines produce depression of the CNS. So, our patient's reaction time is slowed, alertness is diminished, and they become very drowsy. The effects are more pronounced with some antihistamines over others. With second generation antihistamines, we don't really see CNS depression. In terms of the therapeutic uses for H1 antagonists, they're useful to treat allergic disorders very simply. However, sometimes we can use them for other conditions like motion sickness and insomnia. But first, we're going to talk about mild allergic disorders. Antihistamine reduces symptoms of mild allergies by blocking that H1 receptor site. In people with seasonal allergic rhinitis, these H1 blockers reduce sneezing, rhinorrhea, itchiness of eyes, nose, and also throat. In patients that have acute urticaria or hives, drugs can reduce redness, itching, and edema. They can also reduce symptoms of allergic conjunctivitis and urticaria that's associated with mild transfusion reactions from, for instance, a blood transfusion. In all of these conditions, the benefits result from the blockade of H1 receptors, not only from preventing allergen induced release of histamine from mast cells and basophils, but we're blocking it at the actual receptor site. Because mild allergic reactions may be mediated by substances in addition to histamines, antihistamines can't produce a complete relief or complete cure, right? We're only working on histamine. In terms of motion sickness, there are some antihistamines like Phenergan or promethazine that are helpful with motion sickness. And we also have a very popular type, Dramamine or dimenhydrinate. These are labeled for use in motion sickness and are given to people if they're going on a boat ride or a cruise. The benefits derive from blocking the H1 receptor and the muscarinic receptors from the neuronal pathway leading from the vestibular apparatus of the inner ear to the vomiting center of the medulla. Okay, so that's a really important detail in terms of how it's working against motion sickness, so the vestibular apparatus. And There is more discussion of motion sickness and its treatment in a different chapter. This is all you need to know in terms of the use of H1 antagonists for motion sickness. With insomnia, we are able to use antihistamine to cause drowsiness to help with insomnia, but it has been exploited in the treatment of insomnia, specifically over the counter sleep aids. They contain H1 antagonists. Think about Benadryl or diphenhydramine. This is an active ingredient in over the counter sleep aids. However, although antihistamines can induce sleep when used in sufficient dosages, the dose recommended for over counter preparations are usually too low to even be effective. And so, without the help of a provider, you may not be using enough to cause the desired effect in the first place. So again, we can use the table on the next slide to help us to judiciously select a drug, minimizing the effects based on what we want to see with the drug. However, let's talk about those adverse effects that we're trying to minimize. The first one is sedation, and this is the most common side effect of the antihistamines, and it can actually lead to very serious consequences. A person with a blood alcohol level that exceeds the legal limit can also be very similar to someone that is impaired with antihistamines. It can be very much the same. And it's actually worse with antihistamines because sometimes you don't even feel tired, but you have that level of impairment and you don't know. So, any patient that is using an antihistamine has to exercise extreme caution when they're driving or doing anything hazardous and, using heavy machinery at work. These are part of your patient teaching and provider considerations. These patients on antihistamines need to avoid alcohol and other depressants of the CNS because it's going to intensify that effect of the H1 antagonist. Fortunately, though, tolerance to sedation often develops within a few days or weeks. So, as the patient continues to use that same dose of antihistamine, they may no longer feel the same sedative effects. The second generation antihistamines, they exert little to no side effects, remember. So, if you have a patient that you've primarily put them on an H1 antagonist and you're dealing with sedation, you may switch to another one that has a lower sedative profile or switch to a second generation altogether. This can help as well. In addition to sedation, antihistamines cause dizziness, loss of coordination, confusional states, and actually can also cause fatigue. With our older patients, we're especially going to pay attention because they can be more sensitive to these actions. And in some patients, we also might see paradoxical excitation occurring. So even though we're thinking that there's going to be more of a depressant effect, some patients get very excited and overstimulated. I have seen this happen in children that take Benadryl. Also, we can see with our older patients an increase for insomnia, nervousness, tremors, and even seizures. So these are all paradoxical to what you would have thought would happen with the depression of the CNS. CNS stimulation is most common in children, though, and after an overdose. GI effects are very common as well: nausea, vomiting, diarrhea, constipation, and even loss of appetite. The reactions can be minimized by administering antihistamines with food. So, if they're having any type of GI symptoms, tell your patient to take their antihistamine with food. And lastly, here on this slide, we're going to talk about the anticholinergic effects. The H1 antagonist possesses a very weak atropine like property, and these antimuscarinic actions produce drying of mucous membranes, not only in the mouth, but also our nasal passages and even our throat. This cholinergic blockade results in urinary hesitancy, constipation, even palpitations. If our patient complains about dry mouth, it becomes more distressing and uncomfortable. This can be minimized by several um, strategies. We can have them use sugarless hard candy to help with the dry mouth. We can also have them take frequent sips of water as well. And this is, again, assuming there's no contraindications for fluid or candy. But this is why I stress the sugarless part. Antihistamines should be used with caution in patients with asthma because it can cause thickening of bronchial secretions and impair breathing. With patients that are using antihistamines, um, we are looking to see if they're taking any other drugs that can produce an anticholinergic effect because this can make the muscarinic blockade even worse, causing things like urinary retention, BPH, and also hypertension. Just like second generations being lower risk for sedation, the second generation antihistamines are at a lower risk for anticholinergic effects as well. Here is the slide 56.1 that I do want you to pay attention to, the pharmacologic effects of histamine 1 antagonist. And you can see here that the blockade activity of H1 is noted by the amount of plus signs, and you can see the blockade is actually happening in larger amounts for some of these first generation agents than others, and also the second generation agents. Some of them have a moderate to high antihistamine effect, and in comparison to the first generation agents that have a very low to none H1 blocking activity. For instance, one of those drugs that I see here is diphenhydramine. It has just one plus sign to two plus signs. In terms of sedative effects, you can see that actually diphenhydramine or Benadryl actually has a high risk for sedative effects as well as anticholinergic effects. We see the same thing for promethazine, which is also referred to as Fernigan. Note though that if you are selecting a drug here and you've tried another first generation agent, specifically here the alkylamines, which may have less sedative effect and less anticholinergic effect, if you are still experiencing that with your patient, you're going to move then now to a second generation agent, which are all non sedative, and they have low to none anticholinergic effects. One thing to highlight here too is that there is a black box warning for promethazine. It can cause severe respiratory depression, especially in our younger patients, and there have been deaths related to the use of Fernigan due to severe respiratory depression. Now, the drug is contraindicated for any child under 2 years old, and it needs to be used very cautiously with children older than 2 years old as well. That would not be my first choice for an antihistamine. Now we're going to transition and talk about our second generation H1 antagonist. And again, repeating this so that hopefully it sticks, it will produce a less sedative effect than the first gen agents. The second gen agents also cross the blood brain barrier very poorly. So they're going to have a low affinity for H1 receptors in the CNS. So the CNS suppressants are also very low here with the second gen antihistamines. That synergism that we saw with alcohol and other CNS suppressants in our first gen antihistamines are not going to be seen here with the second generation antihistamines. So, for someone that you know drinks alcohol regularly or taking another type of CNS suppressant, putting them on cetirizine or loratadine is going to be okay, or any of these listed here on the second generation page. Now, there are 5 second generation agents that are used for oral therapy, but we're only going to discuss the prototype in detail, fexofenadine. And the other ones you can see on table 56.2, and you may even be more familiar with cetirizine and loratadine. But Fexofenadine, also referred to as Allegra or Allegra allergy, has been approved for PO therapy for seasonal allergic rhinitis and for patients that have chronic idiopathic hives or urticaria. Of the second generation antihistamines that are available right now, this drug appears to offer the best combination of both efficacy and safety, and this is also why it's chosen to be the prototype drug. In clinical trials, the incidence of drowsiness and other side effects was nearly the same with those patients taking a placebo. So it really has a very low side effect profile in terms of sedation and CNS depression. Fexofenadine or Allegra also comes in children um, doses or pediatric doses and in liquid form, and they can also be found in orally disintegrating tablets. So we will see it marketed as children's meltable tablets in the disintegrating form. For all the formulations, dosage should be reduced in patients that have renal impairment. And you can look that up and see what that dose should be, but usually it's about half the dose of a regular um, dose. Keep in mind too, something else to think about when prescribing fexofenadine, that there are certain fruit juices like apple, orange, not only grapefruit, that can reduce the fexofenadine absorption. So if we are reducing absorption, then we're also going to reduce the therapeutic effect. So taking any of these juices while taking these medications can reduce that risk of being able to really feel better or get the um, relief from allergies. The mechanism of inhibition of organic ion transportation of polypeptides contributes to the absorption of fexofenadine from the GI tract. To ensure the fexofenadine absorption, then, we need to tell our patients not to drink fruit juices within 4 hours before the dose or 1 to 2 hours after the dose. Here you can see the table showing you um, H1 antagonists in terms of what their trade name is, their routes, and the usual adult dosage. I do want to draw your attention to the two drugs that come in IV and IM as well. So we have diphenhydramine, marketed as Benadryl, and we also have promethazine, marketed as Phenergan. So if you've worked at the hospital, you perhaps have given IV or IM. Uh, Types of these drugs. And then Phenergan also comes in a rectal suppository. The rest of these medications are only in PO form. With our second generation non sedating agents, cetirizine, you might know as Zyrtec, and these also can be given to children, usually in half the dose, 2.5 milligrams every 24 hours. Remembering too that these drugs only need to be dosed once a day or every 24 hours. Then the other drug that you're probably very familiar with is the Retidine, which is also called Claritin. This can also be given in a half of an adult dose, and we also only give this 24 hours a day. Fexofenadine, which is Allegra, can be also dosed for children, except for children 6 to 11, we're giving it every 2 hours or BID. And for children 6 months to 2 years, we're only giving 15 milligrams BID. The last one here, you might also be familiar, probably more than the Zysol. You might have seen the Clarinex, and this can also be safe for children. So, of the second generation agents, these are all safe for children, but you can see that they're only in PO form and not offered in IV or IM. We should never use antihistamines in infants purely for sedation. But however, note that a side effect is sedation. And it can be used in small doses in children older than 6 months, but make sure that it is used with extreme caution and patient teaching. For children and adolescents, it can be safely used. You saw, especially the second generation antihistamines are rather safe. We're always going to use smaller doses and understand that even the scheduling may be a little bit different, although most of them are 24 hours. There is one that again has the black box warning. I'm going to highlight that again. Promethazine is contraindicated in children younger than 2 years old because we have seen deaths related to the use of promethazine under 2 years. In pregnant women, there's still debate. Many of the drugs are classified again by the FDA based on pregnancy risk. And this um, for these drugs, for antihistamines, the pregnancy risk is a category C. So it's showing that they should be avoided unless absolutely necessary. For breastfeeding women, occasional small doses of an antihistamine have not been shown to have adverse effects, causing sedation in the infant. However, you should still be cautious about using an antihistamine when breastfeeding. And with our older patients, many of the antihistamines that were listed within the Beers criteria. So, what does that mean? It means that most of these drugs should be avoided in older adults. The Beers criteria talks about drugs that have adverse effects for our older populations. Because antihistamines can cause sedation, smaller doses should be used initially and titrated up if needed. Additionally, these meds can cause glaucoma or BPH to worsen. Remember, they have an anticholinergic effect. So, to wrap that up, it's not all the antihistamines that are on the Beers criteria list, but many are. So, you do want to do your due diligence and find out which ones are safe for the older population. The summary of key prescribing considerations for antihistamines is basically figure out what the therapeutic goal is, and usually it's the relief of mild to moderate allergic disorders. And then we want to get a baseline description of any of the symptoms that are occurring. We want to monitor judiciously and think about who is at high risk, noting that patients that may be aggravated by a blockade on the muscarinic receptor. Patients with asthma, urinary retention, open angle glaucoma, and BPH are at higher risk and perhaps should not have these antihistamines. If sedation is an issue, make sure that the patient knows to look out for those symptoms, but it may be best practice to take the medication at night prior to sleep. And if there is GI upset, take with meals, and frequent sips of water throughout the day can help with the cholinergic side effects.